Thank you for joining us on Aesthetic TV. I'm Dr. Andrew Ordon, and along with my co-host, Stuart Brazell, we're going to discuss the most common and popular aspects of breast aesthetics.
This is very important to our female viewers. From breast implants for augmentation, to breast reduction, to some of the newest therapies, including fat transfer or fat grafting to the breast.
That's right, Stuart, and we'll get into all of that and more, but first, let's meet our esteemed panel of experts. The breast men are in the house. I personally am a leg man, but they're going to get my attention, I'm sure. So who do we have today? We have Beverly Hills plastic surgeon, Dr. Ritu Chopra, who happens to be my partner in practice in Beverly Hills, and another Beverly Hills plastic surgeon, Dr. Leif Rogers. Welcome to both of you.
Thank you very much.
Dr. Ordon, first can we break down this term breast aesthetics? Most people would just say boob job.
Well, it goes way beyond breast augmentation to include all aspects of cosmetic breast procedures. We see many women coming into our practices with a wide range of needs. Some want implants for cosmetic needs, some need reconstruction after breast cancer, and some want revision surgery for a variety of reasons, all of which we will get into with our esteemed panelists. So there's a lot more to breast aesthetics than just inserting implants. And I think the public thinks, oh, it's such a simple procedure. We make an incision and we put in an implant. But that is so far from the truth.
I think that's absolutely right. We see it in our practice every day. People that don't know what they're doing and doing breast augmentations, there are a lot of complications to it. Capsular contracture, the implant's malpositioned, pain, and overall the patient's just not happy.
Oh yeah, I mean, when you're talking about breast aesthetics, I mean, of course we have augmentation, but there's even more than even what you mentioned. We have reduction, we have, just changing the shape, we have lifts, we have everything. But if we're going to focus more on the augmentation, the making bigger of breasts, the breast is a very specific unit. I mean, it's not just a mound of tissue. I mean, we do that all the time for reconstruction. You can put mounds of tissue on, but it doesn't look like a breast until you shape it. And the shape is everything.
And that's such a key point for women out there. If I get my breast done, am I going to look like I had a boob job? And it's our job to do surgery that makes sure that you get a great result, the result you wanted, but a natural result. And there's so many other factors involved in doing breast enlargement. You touched on it. What is the breast tissue like that you're beginning with? Is it have a narrow base? Is it have saggy skin? What's the configuration of the chest? Are the breasts naturally wide apart? Are the breasts naturally close together? Are the relationships of the position of the nipple, are they all correct? Because these are all factors that if you don't look at it the first time around, you're going to get into trouble.
I think that's absolutely right. Knowing the patient expectation is key. And we always talk about it. The best way to know that is have them bring pictures in. They bring a picture of somebody and say, this is what I want. And then we say, and we look at their anatomy and say, well, we can't do that. And they have to be aware of that before we go in.
And in plastic surgery, we're always leery to say, bring in a picture. We're going to give you what you show us in that picture. But this is one of those cases where we say, bring in a picture because it gives us a good idea of size
Our
that they want.
expectations.
That's
Yes,
right.
and how it fits the rest of your body. Typically, we say find somebody that has a figure similar to yours and the size breasts that you want on that.
It's just a good way to communicate. And truthfully, there are things we can do to alter your breasts that
We can alter your breast too if you want.
that can make them a little different than what you were born with. Other than making them bigger, we can actually change the shape. We can change the nipple position. We can change how wide or narrow they are to some degree.
Yeah.
But the patient has to trust their doctor to know that we're going to do what's going to be appropriate.
That's right.
Because sometimes
Exactly.
patients ask for things that are just frankly not appropriate for their body.
Right.
Now, I have to ask, talking about pictures, who are most women requesting that they want their breasts to look like?
Well, I think you're looking at me, so we'll start with me. And I've been doing it a little bit longer than my two esteemed colleagues here. So I think over the years, the picture I saw the most of was Pamela Sue Anderson. And the funny part is that she fluctuated. I mean, she went from a B to a C to a double D and then downscaled. So there were a lot of Pamela Sue Anderson.
Lots of
photos
versions of that.
that I looked at. But I think the trend has changed a little bit.
I think that's right. I think the 80s, it was Pamela Anderson. And now in the 90s and 2000, we're going into Jennifer Aniston, sort of a natural looking breast, the one that fits their body, something that's not out of proportion. What do you think?
No, I agree, definitely. The size in general, the request for is coming down a little bit.
Yeah.
And it's funny though, in my practice, for whatever reason, people don't bring in pictures of celebrities. Maybe just because those pictures are hard to find on the internet, because there are a lot of other pictures on the internet you can find easily. So
There's no paucity
We know
of
what you do
photographs.
in your spare time.
You know what I see a lot of are the Victoria's Secret catalogs.
Oh,
I
yeah.
think it's the husband before they come see us in the office. They give the wife
Flipping through
or
the
significant
catalog.
other the catalog and mark page 6 and 7 and say those are my favorites.
Well, clearly this is a topic that's always going to be popular.
For sure, and just to put it in perspective, in 2013 alone, nearly 300,000 breast augmentation procedures were performed in the United States alone.
Wow.
So breast aesthetic procedures have remained in the top 3 most popular procedures ever since people have started tracking these numbers. And according to the Medical Insight research, increasingly women are opting for alternatives to breast implants. And now more than ever, women have more options with regards to breast aesthetics, and that's why we're here today.
So staying with the topic of breast aesthetics, let's talk a little bit about motivation. Why do women decide to get breast implants or an augmentation?
go ahead.
Well, you know, in my practice, in our practice, we see that women want to fit better in their clothes. You know, breasts are a big point of femininity for the woman. So if they have small breasts, they don't fit in their clothes right, they don't feel feminine. So most of the time they want a little enhancement so they look better and feel better about themselves.
And you know, throughout history, the perception of the female form has always been a curvaceous,
Voluptuous looking.
well,
product.
not necessarily, but curvy. In other words, that I can tell that Dr. Rogers has something to say on this subject. Go ahead.
Well, no, it's just, in my practice, I really have two, I think, different types of patients. I mean, I do a lot of breast reconstruction, so I guess really that's a third type if you want to talk about that. But we have the very young patients who really, I mean, they want to look good in clothes, but really what they want to look good is naked. So that's really important to them. And then you have the slightly older population, which isn't older, but older compared to like a 20-year-old. Now these are patients who may have had some children, you know, who have a little bit of, so, you know, deflation of the breast after breastfeeding. They also want to look good naked, but now looking good in clothing becomes more important. So the priorities change, and what they're looking for changes. The aesthetic that they're looking for is also slightly different.
You know, I think you touched on the two big groups.
Yeah.
A, the younger women that never developed breasts, and B, the women that went through having children, that breastfed multiple pregnancies. They want their bodies back. So they are the ideal patients for breast augmentation. As Dr. Rogers said, there's some laxity. The breasts have deflated. They're ready to be reinflated. And
I think it is. I think confidence is a big part of it. You know, women, one of the first things that we think about and we feel that men notice are our breasts. So if you feel great, then
I do.
you have a better day.
I want you to touch on this. You know, we look at breasts all day long. The three of us, it's a tough job,
Tough
but
job.
somebody has to do it. And you know, for you women out there that are concerned that the two sides are not even, I mean, most women are uneven to a certain extent, and a lot of times in surgery, we're trying to even things out.
Well, that's right. It's a three-dimensional structure. So, and most women before breast augmentation don't stare at their breast and look at them and say, okay, that's uneven, that's uneven. But after breast augmentation, if something's uneven, they'll be calling your office every hour. So it's our responsibility to point these out beforehand to show them, you know, no two breasts are exactly alike. They're sisters, but they're not identical sisters.
And that's a big part of where we spend time in the OR is sizing, that we have the patient lying down, we have our pockets created, but we put in different sizes to try to match that size.
And we sit them up to make sure it looks the same, because patients don't look at themselves laying down, they look at themselves standing up. So obviously we sit them up to see how that looks. And then to touch on breast reconstruction, that mentality exists even with patients who have had breast reconstruction, which is, you'd think it'd be a little, I mean, going from nothing to now they're focused on, well, it's a little different. You can make it more the same, which is fine. I mean, my passion to get it perfect, because I'm a little OCD, which I think most
We
plastic
try to,
surgeons
yeah.
are.
You got to be
have
perfectionist.
You have to be that way.
Yeah.
Yeah.
But there are some limitations to what you can do, without totally
Well, and
reinventing
I
the wheel.
think what makes it more difficult is the fact that you have two breasts, very often very, very different, and it's our job to try to make them as even as possible, and at times that can be very challenging.
Yeah, I mean, a couple different components: the skin envelope, the breast mound, the nipple position, and your chest wall. All those things we have to take into account. So
The chest wall is a huge one.
That's right.
And a lot of people don't even think about that. Patients have no idea that their ribs on one side stick out and the other's in. And
That's
Which
really
is going to have
interesting.
effect, and if you have scoliosis,
Oh,
the
huge.
one breast naturally is going to ride higher, and you have to think of it as a roof on a house, that if you have a lot of pitch and you put this implant, it's naturally going to lean out to the side. So these are all issues that we have to weigh.
So for viewers at home who might be interested in getting a breast augmentation, what should they know? What should they think about and be aware of?
well, there's different types of augmentation. I mean, augmentation isn't just augmentation anymore. It's not just putting an implant in, as we said. So you should be aware that there's many different ways to do it. And if you go to a surgeon who really can do many different ways, you get an idea of what's going to be best for you. And I know we have some examples here. So
yeah, so I brought some implants so everyone can see, and these are Mentor memory gel, and why they call them memory gel. So if I cut this implant in half, there wouldn't be liquid silicone. It would actually be a gel, more like a slime. So it won't actually move into the tissues anymore. But it's interesting.
appetizing.
So there's different types of profiles for different people's bodies. Okay, there's a moderate plus, which you can see here, versus a high profile. And you can see the dimensions on these two are very different. The diameter is a lot bigger in the plus, and the height is a lot bigger in the high profile. We also have finally a high profile. And these are for the patients that are very, very thin. So we don't want a lot of breast in the armpit. We want some projection. And these are the ones I use for those.
So a lot of great options with implants. I mean, initially when implants came out, it was really one design, more like the moderate profile type thing, and that was used. But now, as Dr. Chopra alluded to, great options, but it's not just the shape. There are other options, texture and so-called anatomic.
well, the anatomical implants, everyone knows them as the gummy bears.
Right.
Now they're officially FDA approved in the U.S. They've been so for about a year or so now, and it kind of changes the game a little bit. These are great. They will give you a very nice cosmetic result, but there are some limitations. I mean, because this one is so high, sometimes if you don't have enough breast tissue, it can kind of look like a
Snowball.
Just sitting
Most of
there.
the snowball.
That's
yeah,
right.
sitting on the chest.
Yeah.
Yeah.
So in those situations, this is not ideal. Now there are some other ways around it. Again, we'll talk about that later with fat grafting. So there is ways you can kind of make these work as well. But now we have these shaped implants. They're anatomical, meaning if I hold this thing up like this, you can see it naturally has a flat spot here and it's full. These are shaped like that no matter what position you're holding them in. Unfortunately, I don't have a good example today to show you, but literally they're shaped like this all the time. The nice thing about that is if you have a patient who has almost no breast tissue and wants to be a large-breasted person afterwards, if you put that in, it'll actually have that natural shape. This less likely a natural shape. The anatomicals are also quite good for reconstruction, because reconstruction, there's no breast tissue at all. You have some skin and, again, your chest there with no breast tissue, so you have to recreate the entire shape out of an implant. So they're fantastic for that.
So I guess for the audience out there who has questions about the so-called gummy bear anatomical, where would the indications be for sure for reconstructive reasons? But if you are flat to begin with,
if you're very small,
you're starting from scratch, very
Yes.
little of your own breast tissue, that could be.
could be, especially if you want to be significantly larger than you already are.
And I think now is a good time to discuss, placement of the implant, because there's options there, above the muscle, below the muscle, and what we call a hybrid, partially above, partially below.
Well, I think that's right. In my mind, there are three big ways. One, subglandular, meaning just right under the breast tissue where we can put the implant. Other is totally submuscular, meaning right under the pec major muscle, surrounded by the other muscles. And finally, what we do, it's called the dual plane, where about 2/3 of the implant is below the muscle and 1/3 of it is below the breast tissue. This gives you the most natural looking, in my opinion.
I agree. And it's the reason why I think it's important to put some under the muscle is because frequently you can get that sort of like a step-off look. I mean, it looks like...
Which we've all seen.
Isn't it funny now in our practice that our patients almost design the surgery for us because there's just so many pictures, so many results on the internet, and these guys post their pictures and they say, well, I did a 500 cc implant textured placed partially below the muscle, so they come in and they saw it.
They have those
They saw it, they read it, they like the result, and they come in and they basically suggest what we should do. And in some cases,
it used to be you only did that at the hair salon.
It's well, just like
No, I think that's right. You know, they're coming in with so much knowledge. They're like, I want this anesthetic, I want this pain medication, and I want this approach. And I'm like, okay, you
Wow.
can, here's your scalpel.
Yeah,
You
that
do
could
it
be
yourself.
dangerous. That
Absolutely.
Could be great. And patients all the time, I want a 400 cc implant.
Yeah.
It's like, yeah, but that doesn't make sense
You
for
have
you.
a
Your
teeny tiny frame.
yeah, like you're this tall and your friend's 6 feet tall and you're 100 pounds. Your friend's 180 pounds. I mean, that's a big difference.
That's right.
So they don't understand that. They think a cc is a cup size, which it isn't.
Now, Dr. Chopra, I understand you've brought some photos in of before and after of your patients. I'd love to take a look at them.
Yeah, for sure. So this young lady is a 31-year-old female who actually had 2 kids and breastfed. And when I look at her breasts, I see they're partially deflated, and you can see that her left nipple is lower than her right nipple if you really look at it. So what I did is my favorite technique, like Dr. Rogers, is a peri-areolar breast augmentation, dual plane. So right around the areola, I put the implants in. I think they're 425 cc's high profile, which gave her a nice, natural, fitted to her hips, and a great result in my opinion.
Well, I think we all agree that this is some very impressive work, Doctor.
Thank you so much.
and a happy patient, right?
Absolutely. That's what it's
all
about.
There you go. Well, we've talked a little bit about fat grafting. So I want to talk more about how you're transferring fat from one part of the body to the breast in place of an implant for augmentation. And some of the procedures involve using stem cells. Now, this sounds really promising.
Well, it is, but let's try to clear this up a little bit. In recent years, physicians have put advanced techniques into practice using the patient's own fat for both cosmetic and reconstructive breast surgery. And in these cases, called fat transfer or fat grafting, a surgeon uses liposuction to first obtain the fat cells from one part of the body, such as the thighs, the abdomen, the knees we love, and use it for augmentation to reshape the breasts.
Knees, I'm like, that's fascinating.
We
There's
love
that much
knee,
fat in the
knee
knees.
fat's good. You know, that's probably not enough for the breast, but knee fat we love when we're using it on the face. And of course, the Brazilian butt lift,
butt lift.
we take fat from one area of the body that they want to get rid of it and put it in the buttocks.
I have to say, women, not to say anything negative, but women have more fat on their knees than they realize.
I'm fascinated by that.
We call it
Measles.
Measles?
That's right.
There's a term, measles.
Yeah.
Well, you know, it's like all women. We're looking for bigger breasts, smaller thighs, bigger butts. I mean, isn't it just our dream?
Well, it is.
Well, I think
And-
it's all of our dreams.
Exactly.
But Leif, I know that you have you like to use fat grafting in doing your breast surgery, both cosmetic and reconstructive. So share a little bit of your experience with us.
Okay. Well, fat grafting to the breast really did start with reconstruction. I mean, quite a number of years ago, and we couldn't figure out how to fix some of the small defects that persisted after reconstructing a breast, because an implant isn't exactly the same size and shape as your breast that we removed after a mastectomy. So people started taking fat and putting in very small amounts to fill in those little defects, and that worked, and we were amazed that that worked. So we started doing more and more, and people started doing it, putting it into a natural breast. Now that caused all kinds of alarm in the plastic surgery community, because we're like, well, what's happening to the natural breast cells? Are you causing cancer? Are you creating issues? Well, that's all been put to bed. There's been quite a bit of research done in multiple different centers, shows that it does not cause cancer. It can change your mammogram slightly, but in ways that can be identified and sorted out. So it's really not an issue. So having said that, fat grafting works very, very well. And we can do it with high volumes now, meaning I can put 200 or 300 cc's of fat, which, I mean, if you have an idea, let's see. Let's see how big this is. This is probably about 250 cc's, okay? Yeah. So we're putting at least this much fat into each breast that we borrow from somewhere else, where someone may have a little extra anyway, so it's kind of a 2-for-1. Most of the fat survives. Anywhere from 60 to 80% of the fat will survive forever. meaning it's now happy
there.
living fat in a new place.
It has a home.
It has a home.
Yep.
It feels completely natural. If you go to your gynecologist and they examine you as they normally would, they would not know that you had it done.
Wow.
So on X-ray, because the breast naturally is composed of a lot of fat, on X-ray it looks like almost like normal breast
I
tissue.
have to point something out because Kim Kardashian is famous for X-raying her butt, and you know, now I'm seeing how people are getting away with having X-rays, saying they're not getting things done because they're probably using their own fat.
That's exactly
they
right.
want to prove that
Yeah.
they don't have implants, but chances are they had it done the way that Dr. Rogers has discussed.
Now, we've talked a lot about breast augmentation, but I want to hear more about breast reconstruction.
Well, breast reconstruction is a different animal altogether, involving a different set of underlying motives. It's a great option for women who have lost a breast due to cancer or other conditions. And the number of women that undergo post-mastectomy breast reconstruction is reported to be around 40%, but growing all the time. And they're motivated primarily by concerns of body image, but I think issues of sexuality and femininity have to go hand in hand with it. And popular celebrities like Angelina Jolie have brought public attention to breast cancer and reconstructive options.
This was a big story, and I know that you're involved in.
Well,
this
that's
sort of
right. I
procedure.
mean, both of us are involved with it. You know, Angelina Jolie came out very bravely, I should say, knowing that she had what we call BRCA1 or the BRCA1 gene, which predisposes her to have cancer. And what she did is have a bilateral mastectomy. That means take out both of her breasts, even though she doesn't have cancer in them, and get reconstruction. We both have seen a huge uptick of patients coming in for that because of her, and she should be applauded for that.
I agree.
And so many great options available for women that are faced with that decision. And I think a big message here as far as reconstruction, that women don't ignore any symptoms, don't ignore anything that you find changes in your breast. Make sure you get your yearly mammographies over 40. If you have a family history of breast cancer, make sure that you're keeping a good eye, do your self breast exams, and just know that breast reconstruction really has come a long way.
And another thing to really think about as the patient is that a reconstructed breast can actually look really good. They can look very natural. They can sometimes look better than the original breasts. And now that we're doing, again, we talk about fat grafting and how we use that for breast reconstruction, you also get a little body contouring out of it, which is a little bit of a bonus because we have to get that fat from somewhere.
Right.
Exactly.
Now, Doctor, I understand you have another photo for us.
Let's take a look. So this patient is a 48-year-old who had cancer on the left side and wanted a prophylactic mastectomy on the right side to protect her from getting cancer in that breast. And so what I did with this patient is called a tissue expander alloderm reconstruction, where at the first operation I put tissue expanders in and I fill them up until she's happy with her breast size. The next operation I come back in and I put implants into her. Obviously on the left, since it was cancer, the nipple had to be taken. I will make a nipple for her later in approximately 3 or 4 weeks. But overall, you can see her breast symmetry is great. The breast mound looks great. Once the nipple areola is reconstructed, she's going to look like she had a breast dog.
Yeah, that wonderful work again.
And that's something patients should be aware of too, is you can keep your nipple. I mean, it's not all surgeons do that. Not all surgeons are comfortable doing that. And sometimes even with cancer, you can keep a nipple, depending on how big the cancer is, where it's located. For prophylactic, you almost certainly can keep the nipples, though that, again, an option. We can reconstruct a nipple. It doesn't look ever quite as good as the real thing, but it's sometimes pretty hard to distinguish the difference.
And when you add medical tattooing with that is a big help, and some fat grafting that you already touched on. Using those added modalities, we very often can get very pleasing looking.
One of the biggest take-home points for our viewers is that breast reconstruction is available, and they should be asking their surgeon about it, because if your insurance company is covering your mastectomy, by law, they have to cover the reconstruction. So the most important thing is get the information out and ask your surgeon about your possibilities.
I'm sorry, there are some possible limitations geographically, though. That's the one negative. If you're in a place where there aren't that many surgeons, you're out in the country, it's possible that your local surgeon doesn't have a plastic surgeon to work with.
That's right.
So that's something to consider. I mean, and another thing, if you do get a diagnosis of cancer, most breast cancers are very slow growing, which means you don't have to do it tomorrow. You actually have a little time to go get another opinion, go find out who's in the next city. So most people do have a little time. When I say a little time, not months or years, but weeks.
So tell me now, how is breast revision surgery different from breast reconstruction?
Well, revision surgery is when good surgeons fixed surgeries that have not gone well. You can call them botched surgeries if you want. We've seen our shares of those, haven't we, gentlemen?
Oh, sure. Yeah, but there are obviously patients who had results that weren't so good. Now, we've also had our own revisions.
Of course.
And that means basically you do the best you can, and there are little imperfections that you often have to fix. Now, that, believe it or not, is pretty common, partially because we're all perfectionists. We look at our own work and we say, that could be a little better. What do you think? Want to do that little bit to make it better? Those are considered revisions too, but those aren't the big revisions that I think you're referring to.
They're more of fine-tuning,
yes,
smaller scale procedure to even things out or improve the quality of a scar contours.
I think patients should be aware that those are often a part of the package, really, if they want the best possible result. When it comes to things like lifts, and we were making a lot of big incisions. With implants, it's a little different. I mean, we're trying to get a home run the first time.
So what are some symptoms of a botched surgery?
I think there's a couple of things. Number one, there's malposition of the implant. The implant may be too high, it may be too low. The scarring of the incision could be bad. Too much of the pocket's open, so now they have what we call a uniboob, which has to be fixed. So there's a ton of problems, but if you're a safe, board-certified plastic surgeon and you explain the risk to the patients, many times the operation goes great.
I think in talking about breast aesthetics and breast augmentation, the use of implants, we have to touch on capsular contracture. And the formation of a capsule around breast implants happens all the time. It's when they contract, causing firm, painful breasts that, it's not necessarily botched surgery, but it is a complication that we deal with all the time.
Yeah, I mean, in our practice, we see it quite often, unfortunately. We do the best surgery, or another surgeon does the best surgery possible, and they still develop it. There are certain things that we know that may predispose you to capsular contracture. Blood around the implant, talc, infection. So all of us do the things that are appropriate not to get it, but even if we do it perfectly, people still get it.
Can still happen. It
That's
does
right.
happen. It happens actually quite frequently with implants. That is probably the biggest negative.
Absolutely.
It is,
breast
and
implant surgery.
you need to know that going in, that you can always get a certain degree of capsular contracture, but we do have ways of dealing with it if it does occur. There's medications. I think the use of acellular dermal matrix now on tough cases, some women are just predisposed to form the scar tissue and have real severe capsular contracture. We can fix it.
Yes, we can. Most of the time successfully. Once in a while, people, no matter what you do, will have a problem. But fortunately, that's exceptionally rare.
Right. And we have another example, another photo we want to show. If you can take us through this of clearly a pretty severe capsular
Well, that's right. So
contraction
we call
case.
that a grade 4 Baker capsular contracture. They're so contracted that you can see it, you can feel it, and she has pain. And so what I do on this particular case, well, I took out all that scarred tissue, and what we call this a breast revision, it's really a breast reconstruction. So took out all that scar tissue, put that acellular matrix in, and put implants in. The thing about capsular contracture is that any foreign body you put into your body will develop a capsule. If I put a hip implant into you, if I put a knee implant into you, or I put a breast implant into you, we will all develop a capsule. What happens to that capsule can be a few things. Nothing, it can remain completely soft, it can get hard a little bit, or we can get this.
How long do breast implants last?
Well, that's a great question, Stuart, and I think our viewers need to know this. With the older type implants, we found that they lasted anywhere from 8 to 10 years and even a little bit longer. Today's implant has been redesigned. We touched on that, that they don't bleed, they're more cohesive, they're less likely to rupture. The outer shell is much stronger than it was in the past, but there always is a chance of implant failure. When it comes to saline implants, because they're filled in surgery and they have a valve system, they can deflate. And when that happens, you were talking about a friend
I had
of
a
yours
friend, yeah.
that happened to. You know it right away. If you have a deflation, I mean, acutely, you're all of a sudden one of your breasts is going to be a lot smaller than the other side. However, with silicone implants, you know, simply looking or feeling at the augmented breast can't detect an implant rupture in all cases. So in those cases, we need to get an X-ray study. Typically, we like to go to an MRI, and that typically shows a rupture, but isn't always 100% conclusive either. Sometimes if we have a high rate of suspicion, we've got to go in and check it out.
What is the process for fixing it?
Well, fixing it is you go in, you remove it. Frequently, we take out the capsule that's formed. We talked about capsules and all the free silicone that may be in there. Fortunately, the new ones really don't get all over the place. The old ones would literally, I mean, goo. It's a big mess. The new ones, not like that. They come out very easily. However, we usually still take out the capsule, allow your body to form a brand new capsule so there's no free silicone floating around at all. And that's usually all you need to do.
Yeah, but it is an important issue. And you know, overall, around 20% of women will have their breast implants repaired or replaced within 10 years of the original surgery. But typically, as Dr. Rogers said, it's not as invasive a procedure. It may be just swapping implants, cleaning things up a little bit.
So these are all important things for patients to know and what to expect. Any other things that they should be aware of?
Well, there's actually a list of things
Yeah.
that you should be aware of.
I don't know where you want me to start,
Yeah.
but I think, like I touched in the beginning, their expectations. In the beginning, the breasts generally are not what they're going to look like in 3 months. So you have to walk them through that and make sure they understand that when we finish your breast augmentation, there's healing process, and that'll take a good 6 to 8 weeks, and they should be very aware of that.
And they should be aware that it's not a part of them. I mean, implants are a foreign object,
Right.
which means they're not going to feel completely natural. If you lay on your stomach when you sleep, it's going to feel a little funny. It's like laying on pillows. That's what people tell me. And you can also have odd little things that go on that most people never think about, like if you go on a long flight or go skiing. I've had patients complain about how they can hear their implants
right.
like squeaking or something. Yeah, and that's because of the pressure changes.
You're like looking around for
So,
something.
yeah.
It's me.
But they're not dangerous. I mean, you hear these stories of like, oh, my implant exploded while I was on an airplane. No, that doesn't
That's not
happen.
gonna happen.
And you can scuba dive, you can do all these things, but be wary of sharp objects.
That's
You
right.
just got to be cognizant.
To that point, what Dr. Rogers was saying, women that go into pools will say, you know, my body feels warm, but my implants feel really cold.
Cold.
All of them. So you have to be aware of that too, just so you're not scared that something happened to your body.
Right.
All right, one final note. Let's not forget breast reduction surgery. You know, for some women who are disproportionately with large breasts that cause neck pain, back pain, or other physical symptoms, often breast reduction surgery will alleviate the pain and give them a size they can live with. You know, in my practice, I see these adolescent girls, women going through breast reduction all the time. And I think I speak for all three of us. Breast reduction surgery, so rewarding for us because not only are we making patients look better, fit clothes better, but feel better because there's real symptoms that go along with having overly large breasts.
I think that's right, especially for the adolescents. They're being teased. You know, they have large breasts, they're 12 years old, 13-year-old, and they're being teased by everyone because not all the other girls are developed. But they're also going to develop back pain, bra notching, rashes, all these things on top of getting teased. Well, they want relief from that.
Yeah, I agree. The one thing though to consider about doing a breast reduction on someone at that age is that you can reduce them, they can look great, and they can still grow.
That's
they may
right.
need to do it again.
That's absolutely right.
So if it really has to be, I mean, in my opinion, severe enough that it's causing major distress, whether it's physical or psychological, to do that at that age. Because ultimately they likely will need it again, especially if they're already that large.
Well, I have to say, there's been just a wealth of knowledge shared here today. I've learned so much.
Well, that's why we brought in the two pros from
The
Dover
pros,
here.
and you.
Obviously, the breast men have done a lot of these, take it very seriously, a lot of experience, and I think the audience out there has gotten some great information. If you're considering breast augmentation, I think we agree this procedure, some of our happiest patients.
Thank you both so much for stopping by.
Thank you very much. Thanks for having us.
Yeah, it was great. Thank you, guys.
And we should all thank Dr. Ordon too, of course.
You're very welcome. It was a pleasure to be here with my colleagues. You know, although we merely scratched the surface of breast aesthetics, it is a fascinating topic and an enduring one in medical aesthetics. So for Aesthetic TV, this is Dr. Andrew Ordon with Stuart Brazell. Thanks for watching, and remember,
Stay tuned and stay beautiful.